For joining. Take it away, Carmen.
Sounds great. All right, well, we'll just continue to let people in as from the waiting room as they join. Dr. Mack will join us as he can, but I am Carmen Hughes, and I am serving as the director of the National COVID Resiliency Network, effective this past October 1st for what we're calling the No Cost Extension year 4. And we're quite excited to be a part of the NCRN, as we like to call it here. So good afternoon and welcome again. And we're so happy to have many of you joining us today and taking time out of your busy schedules to be with us. And we know that you have many competing activities, conferences, and other meetings going on at this time. So we're thrilled that you're here with us. In alignment with unity and inclusiveness, I would like to share a few important items with you regarding today's meeting. We have communication access, real-time translation, or CART captioning available. If you'd like to access it, please click the CC button and subtitles to view. If you wish to make the captions bigger or smaller, please click the button again and select settings. A new Zoom feature includes the ability to move your captions box to your preference to feel free to adjust as needed. There's also an American Sign Language interpreter for this session. Thank you so much. And to pin their video, please hover over their screen and click the 3 small dots at the top right corner to pin their video. We also have simultaneous Spanish language and interpretation available. And to activate this feature, select the globe function at the bottom of the screen and select the Spanish language. You'll be able to hear the speaker at 20% volume and the Spanish interpreter at 80% volume. You are able to mute you're also able to mute the original audio if you'd like and prefer not to hear the English and only Spanish. We ask if you wish to speak, and we hope that you will, please unmute yourself and begin saying your name. This will help everyone to know who's talking, especially the ASL interpreter and the CART captioner. In addition to stating your name, we also ask you to provide a short image description of yourself, as well as share your pronouns if you feel comfortable. So we really do hope that you will engage throughout today's event. As I mentioned, we really want this to be an engaging hour and a half. When speaking during today's event, please feel to turn on your camera using the camera icon and unmute yourself using the microphone icon. If you do not feel comfortable going on camera or unmuting, you can also use the chat box and share your thoughts. Our team, including myself, will be monitoring the chat box. If you have any technical questions or have any Zoom issues, we've got our Zoom guru on the line with us, and that's Whitney Lockett, and she's standing by to assist. You can chat with her directly, or you can just raise your hand and she'll reach out to you. And before I go to the next slide, I think our principal investigator, Dr. Dominic Mack, has joined, and I will turn it over to him before I go on to the next slide. But actually, Rochelle, if you switch to the next slide, that will also allow some additional talking points. So Dr. Mack, if you are on the line, I will turn it over to you.
Thank you, Carmen. Hello to everyone. I'm not gonna take too much time, but welcome to a lot of old friends. It's good to see you all. And those of you all who have never been in the community exchanges before, welcome. I think Carmen may have said some other things, but you know, COVID is still among us, but also we are here to address all the other needs of our communities. This is about us taking in the information, but also we want to hear from you. We want to make sure that we're sharing best practices. So I want to thank each and every one of you and your communities for participating in this effort. It can go nowhere without you. And so I think the team has a good program for you today. And we thank you for being here.
Thank you, Dr. Mack. I appreciate it. Without you and your leadership, you've done such great work over the last 3 years, and we certainly appreciate you and the work that you have done and will continue to support us and the communities that we serve in this priority population. And so I know many of you are familiar with NCRN, and so I'll run through the next couple of slides for the interest of time quickly as a recap for most, but to others maybe to introduce the work that NCRN is doing in our community partners. But just so you'll know that the Morehouse School of Medicine and the National COVID Resiliency Network coordinates a strategic and a structured national network of state, national, territories, and tribal, local, and public community-based organizations that will mitigate the impact of COVID-19 on racial and ethnic, minority, and rural populations. The NCRN provides awareness of culturally appropriate health education information and linkage to care, helping organizations and families recover from pandemic difficulties. NCRN is created for community, by you all, governed by community leaders as you all across the nation's states, territories, and tribes. So to quickly run through our program objectives, and they're on the screen for you, but I'll just highlight the 6 objectives: to identify and engage in communities, to nurture existing and develop new partnerships, disseminate culturally and linguistically appropriate information, to link communities to resources with technology, to monitor and evaluate, and have comprehensive dissemination to our priority populations. I'm sure you can go to our funding statement, as we are required to do, but just to know that the work that we all are doing is supported from an award from the U.S. Department of Health and Human Services, the Office of Minority Health, OMH, as part of the national infrastructure of mitigating the impact of COVID-19 within racial and ethnic minority communities. And I know that's a mouthful for the interpreter, which is a 3-year cooperative agreement with OMH and Morehouse School of Medicine. The Office of Minority Health has granted us authorization to continue through this fourth year as what we're calling, again, a no-cost extension year, to continue community engagement of our priority populations, to not just focus on COVID-19, but also other related areas resulting from the pandemic, such as long COVID, social determinants of health, and other chronic diseases that are aligned with COVID-19. So we are thrilled that you all are continuing to be a part of the great work that we're doing and that you all are doing over this 4th year. So as we launch into our program, I'd like to talk about what we will cover over the next now hour and 15 minutes. So our objectives today, and we will host 2 of these meetings over the next, I guess, 8 months now. But today we'll focus on explore the impact of artificial intelligence may have on culturally tailored messaging, including COVID-19 related messaging. Discuss barriers to reaching communities through technology, including the NCRN platform. Provide policy solutions for addressing the effects of the end of COVID-19 public health emergency on insured communities. And identify opportunities for NCRN to support and share resources for COVID-19 priorities. Now, we'll say that the objectives that were and the topics that will be discussed today really come from you all. It comes from our partners as we talk about and think about over the last year, what are areas of focus and what are areas that you would like us to continue to prioritize. And these bubble to the top. And so we want to make sure that we continue to look at these particular areas and really drill down in them for you. So as we leave here, the outcomes is to gain a better understanding of how AI and its impact on culturally tailored health information and communication. Attendees will share tools and best practices for reaching their communities through technology, and attendees will learn about policy solutions for addressing the end of the public health emergency of COVID-19. So as we launch into our first presenter, I want to introduce, well, let me just mention our first presentations entitled The Impact of Artificial Intelligence on Culturally Tailored Health Messaging. And it's going to be presented by Dr. Mohammed Idris, who's from here at the Morehouse School of Medicine, and he's a leading expert in the field of artificial intelligence. And we're quite thrilled to have him be a part of what we're doing here at Morehouse School of Medicine and the NCRN project. And Dr. Idris, PhD, is assistant professor here at MSM. He also serves as the associate director in the Clinical Research Center, the co-director of the Beacon Hope Center of Excellence for the validation of digital health technologies and clinical algorithms. He's a brainchild, let me tell you. This man has it really going on when it comes to AI and technology. He's trained as a computational social sciences. His research combines data science and machine learning with community-based research to design more accessible and adaptive behavioral health technologies for chronic disease self-management, as well as leveraging natural language processing to detect topics in patient-provider interactions. And so prior to joining MSM, Dr. Idris led interdisciplinary team buildings, deploying and maintaining machine learning solutions for a variety of clients, including large hospital systems, United Nations refugee agencies, and Garmin. His work has been presented in various academic, policy, and industry platforms, and also encompasses TED Talks and on AI-driven social science, and has over 1.8 million views. He graduated from the University of Washington and Penn State University. So I'm thrilled to turn this portion over to Dr. Idris, really to talk to us about AI. And you see AI in all sectors, but it's really important, and we're excited to hear him talk about AI in this particular space. So Dr. Idris, I will turn it over to you.
Awesome, thank you so much. Am I pulling up my slides or?
Yes, if you pull up your slides, you are a co-host and you can drive your slides.
Fantastic.
There you go.
Right, everyone can see that?
We can.
Oh, fantastic, fantastic. And thank you so much for the too kind of an introduction, Carmen. It's always a pleasure to be supporting you and Dr. Mack in what is a very important initiative. Also, a quick shout out to Dr. Holliday, who I see is in attendance, who kind of invited me to speak today and on this topic. As Carmen mentioned, my name is Mohammed Idris. I'm an assistant professor in the Department of Medicine, where I'll be talking a little bit about my work around natural language processing. And in preparing for this talk, one of the things that I realized is that there actually is very little work on AI and culturally tailored health communication. And so really my goal with this talk is to first start off with providing some of my background on individually thinking about AI and health communication, which I think sets the context as to how I view a lot of these issues. And my hope is in the first part of this talk for this to be a sort of crash course in what is natural language processing. Natural language processing, as I'll talk about more in a second, is really a subset of AI and machine learning that specifically focuses on communication. And of course, there's applications in health. I'll also be providing in the second part of my presentation some specific applications of AI for health communication, and tying that with what the possibilities are for these technologies with respect to culturally tailored health information. But I think it's important to understand that also within the context of bias. And so I'm going to be talking a little bit about bias in natural language processing, as well as what I feel is an opportunity for us to be partnering with community-based organizations in order to come out with better tools that address some of these biases. And then I'll conclude with some thoughts as well. So in terms of my background, as I was mentioning, I did my PhD in what we call computational social science. And there, really, I wrote my dissertation on natural language processing, but specifically doing natural language processing in Arabic. And it really focused on two broader kind of areas. One area, as I'll talk a little bit more about in a second, and I'll have an example on, is this idea of topic modeling. So you could imagine there's a lot of people talking about a lot of things in a lot of documents, and it would take a very long time in order for me to kind of parse that out, right? I would need to read everything. I would need to code those things. I would need to identify themes within those documents. And topic modeling is a more automated approach to being able to do that. And then the second part of my dissertation really focused not just on being able to pull out meaningful information or insights from text, but then also, once we do that, how do we go about modeling that in a way in which we can do sort of predictive analytics, or as I'll talk about a little bit more in a second. Now, after I did that, I actually did a short stint in industry, as was mentioned. And so I actually founded my own technology startup, built a platform called Compass. You could see it on the right-hand side. This was based on a lot of the work that I was doing in the refugee space. It was about 2017, 2018. I had relatives of mine who were coming to Montreal to apply for asylum. And one of the things that we noticed early on was that the social services, and when I say social services, I mean more broadly defined, everything from kind of municipal, like city services, to shelters, to other service providers, really overwhelmed by the amount of people who were coming, and information was also changing very quickly. And so what we did was built a platform called Compass, and use that platform to build an app called Atar that does really three core functions. And again, these are all examples of what natural language processing is. The first thing was, instead of having people select, let's say from a dropdown, what they need help with, what we could do is actually take a natural language input, however they wanted to describe what they needed help with as an input. We built some models that will determine their intent. From that, we had a database of services that they might be eligible for, and we could go ahead and ask them relevant questions. And then once you have an idea of what people need help with and what resources they're eligible for, then we can create a sort of list of all of the things that they need to do in a particular order with all of the information that they would need, right? So you can click a button, you can call, you can click another button, it would open up Google Maps, so on and so forth. But really this idea that these technologies can be useful for helping with things like patient navigation, social service delivery, but the core of that really is the ability to communicate with a social service provider and then being able to point you in the right direction. After I did that, I took actually the same platform to a second postdoc at Mount Sinai, and we adapted it for patient education around COVID, environmental health exposures, and now we're working in cardiovascular disease. And I could talk a little bit more about that in the Q&A, but again, you could kind of see the reoccurring theme here, right? Is that really communication at the end of the day is being able to understand concerns and being able to provide information in a way that's hopefully actionable, right? And so here what we did was built a platform that allows us to adapt a risk communication strategy called message maps that really focuses on first identifying community needs, and then partnering with community-based organizations in order to be able to develop content as well as disseminate that content to community members. And specifically now, and this is the point that I'm going to end on, through trusted intermediaries like those on this call. And now I'm spending a lot of time as a faculty member applying these techniques to better understand, as Carmen said, patient-provider communications. And here's an example of what that might look like, where you can have a conversation happening between two people. And what you could do is you could build models that will identify key features, whether those features be topics or, for example, other entities like locations or intent, things like that. But now, taking all of that into account, really what I hope I've done is provide you kind of some high-level understanding of what is possible. Really wanted to take a step back and really define kind of within the world of artificial intelligence, what is the subset of techniques and technologies that's specific to communication. And so if we're going to do that, I think it's important to first define what artificial intelligence is, right? There's a lot of hype around it. And really, you could think of artificial intelligence as a subfield of computer science that focuses on the use of computers to make decisions in the same way a human would, right? And that's one of the amazing things about ChatGPT, right, is that it almost feels like you're talking to somebody. Now, artificial intelligence encompasses a variety of different techniques. And specifically within artificial intelligence, when we say artificial intelligence, we're usually talking about machine learning. And machine learning is really the study of the design of computer algorithms that learn from data and improve through training in the same way you or I would. So for example, you could imagine being a child. You don't really, understand, let's say, shapes, right? Or for example, the difference between a cat and a stuffed animal, for example. But as you see enough examples of that over time, you are essentially learning how to identify these things. And so if we could leverage statistical approaches to be able to mimic the idea of learning, using an algorithm, that's essentially what machine learning is. And then finally, within that, we have a subset, which is really the talk of the town right now, or has been, I would say, in the last 10, 15 years, this idea of deep learning, which is a subset of machine learning that uses a very specific technique called a neural network. And the thing to remember here is that the name and the structure of a neural network is inspired by how the human brain works. And it mimics the way that biological neurons signal to one another. Again, this is as technical as we're going to get in terms of deep learning, but suffice it to say that natural language processing really does fall within artificial intelligence. And there are applications of natural language processing that I'll be focusing on that are based primarily on machine learning as well as deep learning. But of course, there are others. So if we're going to take a step back then and really come up with a definition, a common definition for what natural language process is, it really is combining everything that we've learned around linguistics with statistical and more machine learning-based approach to enable computers to process human language. And again, remember that when we talk about human language, I'm going to be focusing on text, but it's not just text, right? You can communicate. It's not just what I'm saying. It could also be how I'm saying it, right? And so voice is a big example of that. You could also, there is nonverbal communication, right? So even video data is an example of the sort of data that's relevant within natural language processing. But the really main goal is, again, to mimic the way humans interact with one another. And that is understanding what inputs are, being able to determine intent, sentiment, and we'll go over a few use cases. Now here I wanted to just provide a very quick, brief history on AI, machine learning, and natural language processing, because we kind of tend to think like these things, came up in the last, let's say, decade or 15 years. But the reality is that these ideas have been around since the 1930s, 40s, and 50s. They were introduced, the idea of leveraging machines to do translation, automated translation, came up and was widely used in World War II. This idea of being able to represent language as being sort of individual words, and those words, a sentence being a distribution of those words in a particular kind of communication, again, came up in the 50s. We had in the 60s and 70s a lot of rule-based algorithms. And when I say rule-based algorithms, you could imagine basically teaching a computer or writing instructions for a computer that if you see this as an input, then I would like you to spit back something, right? So it's a bunch of different rules that came out in the 60s and 70s, particularly around the area of mental health. But again, because they're rule-based, they're very limited and really didn't mimic this idea of being able to ask it any question, because if it was a question that exists outside of those rules, then the computer wouldn't be able to understand. In the 80s and the 90s and going into the early 2000s, right, there were a variety of new techniques, particularly statistical approaches to modeling a language that were introduced. but it really wasn't until the 2010s where we had the perfect combination of data, right? So you can imagine all of the data on the internet that ChatGPT is trained on, right? As well as computational power. So we went from, for example, in the 80s where a computer took up an entire room to now in 2010, we have supercomputers in our pockets. That we really were able to really see these amazing advancements. And a lot of them came from two particular techniques. The first one being a word embedding. So you could represent then a sentence as a vector instead of representing it as individual words. So you're kind of keeping track of the order of the words as well. And then finally, as we've seen, this idea of basically being able to train a massive model on everything in the internet, what's called transformer models, to do some really interesting stuff. And the really interesting stuff that we'll talk about within the context of culturally tailored health messaging is this idea of large language models. And again, my goal in this is to provide a high-level overview or history of these techniques, not get into kind of the technical specifics as to how they operate. I can do that in the question and answers. But here, I wanted to illustrate that while we really were introduced to the idea of large language models with ChatGPT, and you see that on the bottom right here in 2023, there actually have been a lot of advancements starting in 2019 that really built up to getting us in this place. And a lot of this was driven by really large tech companies like Google, for example, where they had, again, the tons and tons of data, right? Including, the billions and billions of queries that people are putting into Google, as well as the computational power, right? To be able to analyze the data in a way where they're able to develop these models. And now we have amazingly capable algorithms. And for example, here we see at the bottom here, Stable Diffusion. Stable Diffusion is a good example of what we call a multimodal large language model, where it doesn't just have the ability to generate text, but we now have the ability to even generate images as well, right? And you could imagine, with a lot of power, as we'll talk about, comes also a lot of responsibility, right? Because I could easily use these technologies to come up with culturally tailored health communications, but you could imagine in the age of misinformation, these are the sorts of technologies that we're going to have to contend with. Because when we're passing, for example, misinformation on the internet, now it's going to be in the form of video and things that is going to be indistinguishable for us to determine whether it's real or not. So now we've talked about kind of the history. Now, I think what's really important is for us to appreciate the fact that we are not computer scientists. We are not interested in technology for the sake of technology. One of the things that I try to reiterate and try to remind myself of is that technology is a solution. It is not the solution. And if we want to use that framework, we really have to understand the idea of use cases. And the idea of use cases is really taking into account, for example, the different modalities, text, audio, and video, having a process to do very specific things like, for example, translation, identifying specific entities, identifying relationships. I talked about topic modeling, and for example, sentiment analysis as well. And the last thing I want to talk about before I get into these specific examples is this idea of thinking about the different use cases along this continuum of higher levels of complexity. The more complex it is, the more valuable it is, right? And so, for example, we can do natural language processing that allows us to understand what happened in terms of descriptive, and I'll give an example of that in a second. Why did it happen? That's diagnostic. I'll give you an example of that in a second from my research. But ultimately, our goal is to drive behavior, right? So we should really be thinking deeply about how we can leverage the tools and identify use cases to build technologies that are really driving the sort of outcomes that we're interested in. So here's one of two examples that I wanted to talk about briefly, where we have these massively open data sets online with social media. And we can do this thing called infovalence, where we're analyzing all of the structured information in order to inform public health and policy. And so, for example, as a particular, like, for example, during COVID or in other cases where you have these fast-moving environments, we can kind of use social media and identify topics from the social media, right, in order to understand and predict outbreaks, to monitor public health responses to health issues, as well as thinking through some of the dissemination, as well as thinking about misinformation. And so here are two visualizations that I'll just go over briefly. that come from an analysis of misinformation and public health messaging in the early stages of the Mpox outbreak. And what they did was really two things. The first thing was they did topic modeling on the tweets in order to identify clusters or ideas that are out there. So basically getting all the similar tweets and kind of getting them, clustering them or grouping them together and then labeling them as being relevant. And then we could also look at the cumulative message volumes per cluster to look at kind of what are people talking about and how is that, for example, changing over time. Here's an example of topic modeling patient-provider interactions, where essentially we built a model that identifies keywords that are really important, meaning that you could imagine when there are in any sort of communication, there are words that occur frequently, and so they're not really helpful, like stop words and that don't really provide any meaningful information. But we also don't want to identify words that occur so infrequently, they're not really relevant, right? And so if we're identifying things, for example, like anxiety, stress, different variations of these words, it starts to tell us a little bit more about what the conversation is actually about. And if we're able to identify those topics, then we can develop really cool and interesting plots here. And so let me take a quick step back and provide some context for this analysis. Essentially, this comes from a research study where I believe this is a diabetes self-management intervention, and you basically have folks partnered with health coaches, and they essentially, after X amount of time, they were working with them, developing self-management strategies, and we clearly saw that there was a difference between some patient-provider, some groups, they were able to succeed in terms of their health goals, and others that they weren't able to succeed. And so what we wanted to do is we said, okay, well, if we know what the topics are, and we could predict the likelihood of a topic coming up based off of whether or not the participant or the coach, we can develop these plots where, for example, we can see here that all of these topics, whether it be monitoring your blood pressure, using consumer health IT technologies, healthy coping, sleep, diabetes knowledge, so on and so forth, were equally likely to be brought up by either the coach, the provider, or the patient, right? And that's a good thing, right? That means that there is a lot of back and forth happening across these topics. But now if we look at the group that was not successful, we see that everything is more likely to be brought up by the coach. And you can imagine what that looks like in real life. It's essentially the health coach or the provider in this case that's talking to the person and not really talking at the person, there's no real conversation happening there. Again, this is an example of going from collecting natural language and processing it in a way where we're able to come up with some interesting insights. Now, let's bring this all back to culturally tailored health communication with large language models. And what I wanted to do here real quick is a short little experiment. I literally typed into ChatGPT, give me some examples of how AI can influence culturally tailored health communication. And if you notice here, some interesting, kind of like it provided something, okay, there might be something here. But if you really look deeply, it's kind of, honestly, they're just throwing the word cultural in a lot of these things, right? So again, it's to suggest that we're quite not there for being able to leverage these technologies. I'll talk about why that is in a second, but suffice it to say that it is only in theory that large language models can be harnessed to create culturally sensitive and personalized health information. And so what are some real use cases, some that we're exploring, and I'd be happy to kind of follow up with people answering question and answer what this actually looks like. But some real use cases are, for example, simplifying language or the idea of translating materials. These sorts of techniques have been around for a very long time. Large language models just take that to the next level. Another one that I'm really interested in is this idea of leveraging these technologies to develop what we call multimodal health education materials. And so you could imagine for some people, text is better. But for other people, it might be some sort of imagery that might be better. And for other people still, it might be some sort of audio better. You could imagine in each of these circumstances, you could imagine probably somebody where that's better suited, as well as thinking about the various mediums by which information is now being distributed. For example, TikTok versus Twitter, right? Again, there are a variety of different modes of data, types of data that are relevant. I want to bring up, though, this idea of red teaming, right? Which is really important. This idea of red teaming is that, these technologies have the potential, but we really don't know what their limits are. When I tell you quite literally, the way ChatGPT was developed is that they had no idea what the outcome was going to be. They just invested tens of millions of dollars of essentially modeling every single thing on the internet to see what eventually it could do. That's kind of how it worked. That was the intended outcome. So we really don't know where the limits are. And there is from that a lot of bias that comes in. And I want to really end on that note of bias. Now, what are some sources of bias, right? The number one important thing that is a source of bias, in my opinion, is the lack of diversity in training data. And so unfortunately, there is a lot of, am I allowed to say crap? Yeah, there's a lot of bad things on the internet. And so the reality is these models are taking all of that stuff in, right? And so it's not really the model itself that's being biased. It's simply a reflection of the information that's out there. And for better or worse, that information is reflective of our society. And so we will have structural inequalities built into that data. There are, of course, other algorithmic design choices, like, for example, what are the specific attributes within a data set that I'm choosing to include in my model that could lead to biases? And then finally, the inadequate testing and the validation, which was why I brought up the idea of red teaming, right? This idea of we need to continually be testing and validating these models before we put them out in the real world. And here we have kind of three just really quick examples. On the bottom left is a paper from 2020 where they're able to show that the error rates by race and gender for speech-to-text algorithms that you'd find on your iPhone very, very poorly for people of color. Here's another example which hits close to home to me, being Muslim. If you were to ask GPT, which are the technologies that ChatGPT is based off of, now there are safeguards in place. But back in, if you were to just type in a prompt that started off 2 Muslims walk into it would give you a variety of very, very racist, very difficult to digest outputs. And then, of course, there are algorithms out there that are, for example, detecting hate speech, which you could imagine it's not surprising that tend to be biased against folks of color as well. So to conclude, just wanted to kind of remind us that really we shouldn't be talking about natural AI. If in health communication, we should be talking about natural language processing, which are the techniques that we're applying to communication. It's not just text, it's also audio and video. Really, the use cases are what matter at the end of the day, but we really, really, really have to appreciate this idea of bias in the data that is being used to train these models. Because one of the things that I like to remind myself on is that if these technologies, if this innovation is happening at a sort of compounding rate over time, it just is increasing. What was possible in the last few years, we've probably done more in the last 20, 50 years. And these technologies are biased. That will, while they are amazing in their capabilities, they will unfortunately lead to greater health disparities. And I really think here there's an opportunity for research on the impact of AI and culturally tailored health communications and messaging. And I want to emphasize here that is, I don't mean this to be just a theoretical exercise, something that we should be publishing in academic journals. I think there are real world implications, and there really is a role that community-based organizations must play in trying to understand and really take advantage of these tools. Really are the tip of the spear. And with that, just wanted to say thank you for the opportunity to present. If we have any trainees, undergrads, graduate students, postdocs who are interested in this work, please reach out to me, as well as faculty collaborators. And then finally, at my core, I always tell people I am, an entrepreneur playing academic. And when I say the word entrepreneur, I really mean taking these technologies to the last mile and really partnering with community-based organizations is a really fundamental part of my work. And so if there are partners out there who are interested in some of this work or even have ideas about how to do potential use cases, I would love to explore that with you all. Thank you so much for the opportunity to present.
Thank you, Dr. Idris. Very, very informative. I think you also gave our interpreter a run for her money. That was a lot of great information, and I started trying to keep up. So I hope that everyone received the information that was needed. Are there any? We really well, we have maybe a minute for questions, or we can put questions in chat and Dr. Idris can pick them up there.
Fantastic. And I apologize for going over here.
No, great information. Thank you for sharing.
All right, let's see.
So Rochelle, I will turn it over to you at this point. Thank you again, Dr. Idris.
Fantastic.
Yes, thank you for the informative presentation. Next, my screen will go next. Next, we will discuss the barriers to technology for communities and potential solutions. And we will have NORC present. So I will introduce our two speakers from NORC. Bear with me. So first we have Jennifer Berchtold, a principal research scientist in the public health department at NORC. Jennifer's work focuses on health communication, social marketing, campaign evaluation, and program evaluation. She recently led a multi-mode evaluation for How Right Now, Kehester Ahura, I hope I pronounced that correctly, CDC's campaign to promote and strengthen the emotional well-being and resiliency of populations adversely affected by COVID-19 related stress, grief, and loss. She is currently technical lead of a multi-mode evaluation for CDC's National Center for Immunization and Respiratory Disease to assess effective strategies to enhance adult immunization uptake and advance equity among disproportionately affected adult population. Jennifer earned her PhD in sociology at the University of Chicago. And we also have Shalonda Henderson. She is a data scientist in the Healthcare Evaluation Department of NORC. Her work focuses on healthcare program evaluation, health equity, and data ethics. In addition to her role in evaluating the NCRN project, she actively assesses the impact of substance use disorder and behavioral health conditions in rural Medicaid and Medicare patient populations. Shalonda also leads data reporting and performance analysis for a Medicaid Medicare health plan serving those in intellectual developmental disability communities. She holds a master's in public health from Emory University and is committed to leveraging data to enhance healthcare outcomes and equity, especially for those who are historically marginal, especially for those in historically marginalized communities. I welcome Jennifer and Shalonda.
Thanks, Rochelle. Hi, everyone. Thanks, Rochelle, for that very kind introduction. Looks like my screen sharing is disabled. Can that get enabled so I can go ahead and pull up slides, please? So as Rochelle mentioned, my name is Jennifer Berchtold, and I'm a principal research scientist at NORC at the University of Chicago. Joining me today is my colleague, Shalonda Henderson. We have a very interactive discussion planned for today. So I'm going to invite you to join in, and I thank you in advance for your participation. My talk today is a little unusual. I don't have a lot of talking points planned, but we do have some interactive polling for you. And so this is an opportunity to hear your experience and share with each other. Shalonda will be taking notes, and she'll provide a recap at the end. Let's see. I don't see. Let's see. Do I have the ability to share screen at this time? Yes, I do. Let me do that. All right. Can folks see my screen? Rochelle, I'm looking at you. Can you give me a thumbs up?
We
Awesome.
can, yep.
Good times, thanks. All right. Just a little bit of background. The Morehouse School of Medicine is interested in how technology can be better used to help NCRN partners reach your communities. NCRN's database and website is a big part of that effort. The website, as many of you know, has a lot of information to support partners in their efforts to reach their communities. There's a support finder tool that connects to resources in the local community. education resources, peer-reviewed research, and it's supported by Google Translate, which translates the website into over 10 languages. Through partner meetings like these and informally, Morehouse School of Medicine has been hearing feedback about the website, including about some challenges. So our team has been brought on to help explore that further. In the next month, we're going to be conducting some usability research to help understand important features of the platform and to identify some areas for improvement moving forward. Today is a first step on that. We want to hear more, and this is also an opportunity for you to learn from each other. What does the NCRN website do well? What challenges have you been encountering? And how have you been navigating those challenges? So the goals for our research are presented on this slide. We would like to increase our understanding of how the NCRN website has been helping you impact your audiences. We want to identify features that can increase the number of website users coming to the website and enhance the experience once they are at the website. We want to understand your current and emerging information needs, especially coming out of the pandemic. What's next for you? And we are interested in hearing how we can continue to do a better job integrating your feedback into website technology. Okay, that's enough of me. For the rest of our time together, this is going to be a facilitated discussion based on your feedback. So I invite you to go to slido.com, where we have some live polling that will inform the rest of our time together. You can use the QR code here, or go to slido.com and enter in the number 3856350. This is a question that's waiting to get to know your all's target audiences, and we'll begin there. So this first question, as you guys can see, which of the following communities does your organization serve? This is a check all and apply. I'm very excited to see that responses are starting to come in, but let me give you a minute or two to continue in. We have a number of different populations that NCRN has been attempting to reach. So they are all included here, but it looks like the display is a little bit, I'll have to be scrolling so we can all see. $18 folks responding so far. Thank you for that. As we can see, it looks like, and definitely responses please continue to come in. There's a lot of other questions that we are going to be asking. So some of them a little more interactive than this one, but this is really a get to know you for the folks that are on the call today. 20 folks that have come in. Thank you. 21. So as we can see, it looks like a lot of you are trying to reach Black or African American audiences, 62%, more than half Hispanic Latinx audiences. We also have quite a few of you that are looking to reach migrant workers, API, a quarter reaching Native Americans and justice-involved populations. Some other ones too, looks like intellectual and disabilities, about 10%. So I think it's really, thank you for this. I think it's great to see that we have a set of people here today that are reaching really diverse audiences. It looks like folks on the call have a number of different audiences that they're looking to reach. In the interest of time, why don't we move on to our next question? So here's the next one. How often do you visit the NCRN website? And I've got the URL up here, ncrn.msm.edu. That's just as a reminder. This website links to the homepage for the NCRN website. like about 14, 15 folks that are coming in. Let's see, once or twice a year. I'm seeing monthly. Less often. No one who's never gone. This is great. Looks like we've got about a plurality of folks that go roughly monthly, some folks once or twice a year, some power users going weekly, some folks that go a little bit less frequently, but of the folks, the 22 of you that have kind of logged in, looks like everybody has gone at least once. Thanks. This is very helpful as we get a sense of the usage and the familiarity of folks on the call with the website. Let's move on to the next one. So here I'd like to hear your satisfaction. For those, for those of you that have been to the site, please rate your satisfaction on a scale of 1 to 5 stars. Folks that are saying 4. We've got some folks that are rating it a 5, and we have some folks that are rating it a little bit less, and that's nice to see. It's good to see the variety and the range. So at this point, I'd like to invite you to please feel free to come off of mute, or you can drop a comment in the chat. For those of you who are giving it high marks, 4s, 5s, what are some of the strengths of the site? What are some features that you really like? And just for what it's worth, I'm having trouble seeing if any notes are in there. So Shalonda, can I ask you if you're managing to monitor the notes of folks coming in with dropping anything in the comments?
Yep, I can do that.
Thanks.
Dr. Berthold, we're also looking as well.
Mm-hmm.
Yeah, I think one thing to note is that we didn't include the Mexican indigenous community into our priority population.
Mm-hmm.
Someone in the chat mentioned this is an important part of capturing this type of information.
That's a great point. Thank you for that. For those of you who gave it 2s and 3 stars, tell me a little bit about that. What limitations or challenges have you been encountering with the website?
We do have a comment that says the site is a bit information overload, but overall it's very interactive.
Natalia, you want to come off with me to say a little bit more about that? You don't have to if you don't like, but I'd be curious to hear a little bit more about the information overload piece.
I think it's just a personal problem because of my disability. Yeah, because of my disability, but assuming if I had the proper guidance as someone else read it for me, it'll be perfect. But by myself, I think it's a little bit much. But if I happen to like slow down or just have someone else read it for me, it'd be great.
Wonderful. I really appreciate you weighing in. Thank you so much for that. Others who gave this 2 or 3 stars, tell me a little bit about what kinds of barriers you've been encountering.
I guess I can hop in really quick. So I do like the tool for like the community health snapshot, or the ability to find information that's salient to like your specific zip code. But I think with the end of the public health emergency, the data might not be quite as useful. And of course, it's noted here on the website itself, but I just plugged in my zip code and it didn't really tell me percentages about like the severity or anything really. So I guess I understand it's a challenge to contend with the data collection with the end of the PHE, but maybe having to pivot with the tool to make it useful or still useful despite that data challenge would be something helpful.
That's wonderful. Yeah, thank you for that information. That's helpful. We have a question coming up that I think I'm hopeful that we'll speak to some of the pivoting, because I'm curious to hear what comes next for folks. What features are missing on the site that you would like to see? And feel free to come off of mute or drop suggestions in the chat. Thank you, Jesus, for that. Gracias. Seems like a real strength of the site that it has information for that can speak to the indigenous communities that from Central America and Mexico, and that there's other languages. That's great. Thank you. Kelly, that's a great question. So are the events under the events tab populated by only what by folks submit? Wondering how to better leverage that part of the website. And Carmen, I get please weigh in here. My understanding is that yes, those are member submitted information, correct?
Yes. I think Laura's on the line as well, but generally that is the information that our community partners submit is added to the platform, the website. Yes, that's correct.
Callie, in terms of leveraging it better, what do you think is needed there? Is it just more events need to be leveraged, or is there a more information needed to so folks understand how to submit events?
I'm relatively new to this network, so I don't have experience with needing to have submitted an event, but I wonder if that's just another hurdle that maybe CBOs aren't willing to take on because it's like another thing that they have to do to get the word out there. But yeah, I'm just wondering if there's a way to reduce the maybe admin burden of like community organizations having to maybe fill out a form, or again, I haven't had to submit an event just yet, but I kind of liken it to asking folks to fill out surveys. Like it's just another like red tape sort of burden. So
Mhm. That's great. Yeah, thank you for that feedback. That's great. How have other folks on the for folks on the call, has anybody suggestions for this, or have you navigated that? Let's move on to the next question. This one is aimed mostly for those of you who have been going to the NCRN website, which is everyone that's responded to the poll. So just a quick one. When you have been visiting the website, do you primarily use a mobile or a desktop device, or both equally? On the call have been using desktop, but I do have a follow-up question for those of you that have been using it both equally. And again, feel free to drop this in the chat or kind of weigh in. What kind of issues or how experiences have you been finding on the by using mobile devices to access the site? How has the mobile app been to use? I am going to move on because I've got one final question for you guys, and this one I'm very curious to hear. This is an open-ended field, and your results will show as a word cloud along with others. Here's the question. Beyond COVID-19, what topic areas would your organization like to have more data or resources for? So let me give you a minute just to enter in your responses. I'm very curious to see what you all have to say here. John, thanks for that feedback on the mobile screens. Some of the graphics have not been responsive. That's great. That's helpful to hear. Thank you. Jesus, mental health. Okay. Thank you. Looks like I'm seeing some trends here. Several folks mentioning mental health, salud mental, workforce, long COVID, health equity, various health equity topics, BIPOC communities, health equity, economic mobility. Food deserts, diabetes, behavioral health, mental health intersection with COVID, chronic conditions, long COVID. So we definitely see some convergence, mental health issues, health equity issues, long COVID.
Dr. Bertrand, there's one in the chat that aligns psychology.
The psychology also sees salud mental.
Yeah, it's only mental, yes.
Mm-hmm. Let me give the one more person who's typing chance to weigh in, and then I think we'll move forward. This is very, very helpful for folks, and it does seem like we have several topics that are having convergence. I see mental health for many people, psychology, long COVID, then chronic conditions that may include diabetes, among others, and it looks like a lot of a lot of you working in the health equity space. So at this time, Shalonda, let me hand it back over to you to kind of recap briefly what we've heard so far. And then, well, sorry, guys.
Yeah, I can do that. It's just one slide. I can just discuss what I have, Jennifer.
Okay, that sounds good.
Yeah. Okay, so thanks so much everyone for your participation. We've covered and shared a lot of information during this segment, so I just wanted to take some time to briefly recap our discussion, and then we have some time at the end if you guys have any questions or any additional comments on our presentation today, then that would be great. So some of the things that I've jotted down, some of the common things is that there's a variation in how often people are using the site, but it seems that those who have responded, most have at least visited the site at least some point in time. It's seeing that most people overall are satisfied with the NCRN website, giving it like a high mark. And some of the features that we've discussed, some people have used, and the ones that we mentioned is that the NCRN website has the capacity to translate current materials on the site into several different languages. You can use the website to find resources and information to serve your priority population, such as educational articles, and so the supporter finder tool. And that we can also access the platform via the mobile app, in addition to the website desktop version. We also discussed some of the overall barriers and challenges. I know someone mentioned that the information can be information overload on the site. And this may not be as conducive for some of NCRN's priority populations. There may be room to keep tools on the website updated and accurate, even as we pivot away from the public health emergency. There may also be room to better leverage the NCRN events on the website to make it more user-friendly and easier to navigate. And in regards to the mobile use, some of the graphics are not as responsive. So this is like an opportunity to update the mobile app version to be more user-friendly. And then lastly, the topic areas that some of you say will be great to have more data and resources on, include things like mental health, social determinants of health, long COVID workforce, community health workers, chronic conditions, and health equity.
One
think-
last question that just came in. So most of you said you use the desktop to access the NCRN website, but what do you think about your communities? So for the communities that you serve, what if they were to go to the NCRN website, what form of technology do you think that they would use the most to access the site? Thank you for weighing in. It seems like there might be a little bit of a difference here. So while so many of you are using the desktop, it seems like your communities might be looking either certainly mobile devices for the majority of them, and then certainly a fraction of them, or some subset as well that could access to via desktop. So definitely seems important to be thinking about both mobile and desktop environments. Thank you for that. All right, let me go ahead and share it. I think we're at our time at this point. So Shalonda, thank you for the recap, and thank you for your time and participation today. Rochelle, let me hand it back to you at this point.
Our next presenter is Gracie Trinowski-Rice. Gracie is the Deputy Director of Policy Research for the National Association of Community Health Centers. Gracie is based in Washington, D.C., where she leads quantitative and qualitative research efforts and designs data-driven publications to inform policy priorities. Her recent research topics include health center workforce development, Medicaid public health emergency flexibilities, behavioral health, cost savings, telehealth, and the 340B drug pricing program. Gracie previously conducted behavioral health research at Emory University with the focus on substance use disorders, neuropsychiatric diseases, and early life stress. And now I will turn it over to Gracie to discuss potential policy solutions to the effects of the COVID-19 public health emergency's end.
Thank you, Ashley. Can everyone hear me okay? See some nodding. All right, I'm going to share my screen. All right, can folks see my slides? I'm seeing some nodding, so I'm going to go ahead and get started.
Yes, we can, Gracie. Thank you.
So hi, everyone. My name is Gracie. I'm the Deputy Director of Policy Research at NAC. And really happy to be here with you all today. I know we're running a bit behind schedule, so I'm going to probably talk quickly to try to get through as much content as I can and still respect everyone's time and schedules. So I'm going to just give an overview of the policies that are relevant to the public health emergency and the unwinding. sort of some level setting, and then talk about specifically Medicaid renewals and how that's going, and then access to COVID-19 vaccines for uninsured and underinsured patients. And throughout that, I'll share some NAC resources and hopefully leave some time for a little bit of discussion. So just so everyone's on the same page, there are some key COVID-19 public health emergency measures that were taken. The first is the Families First Coronavirus Response Act in March 2020, which is the act that instituted the Medicaid continuous enrollment requirement, which basically required state Medicaid agencies from their regular eligibility renewal and redetermination process by prohibiting termination of ineligible individuals. And this requirement was a condition of receiving the temporarily increased federal Medicaid match rate, also known as the FMAP. And so in order to receive the enhanced FMAP to alleviate some fiscal stress during the pandemic, states had to follow the continuous enrollment requirement where they didn't kick anyone off the Medicaid rolls. So these changes led to some unprecedented Medicaid enrollment numbers and declined uninsured rates across the country, and also increased federal Medicaid spending. So by March 2023, there were 93.9 million individuals enrolled in Medicaid and CHIP, or Children's Health Insurance Program, which is a 33% increase from February 2020. So that 3-year span increased by 33%. And this increase was largely driven by increased retention of existing enrollees rather than new applications. A few other key measures to mention are the CARES Act, also passed in March 2020, which mandated coverage without cost sharing of vaccines, tests, and treatments related to COVID-19 by both public and private insurers. And this mandate was tied to the Public Health Emergency Declaration. This act also expanded coverage of telehealth services within Medicare, private insurers, and at federally funded clinics like community health centers. And this has actually been extended through the end of 2024. So I'm not going to talk too much about this today. And then, lastly, it's important to mention the American Rescue Plan Act, which gave health centers $6 billion for COVID-19 response. And the Inflation Reduction Act, which also enhanced marketplace premium tax credits for folks who are buying their health insurance on the marketplace. And I'll pause here. I didn't give much background on community health centers just for the sake of time. But these federally qualified health centers are funded by the Health Resources and Services Administration through the Public Health Service Act, Section 330. So you might hear them called 330 funded health centers or federally qualified health centers. And these are the organizations that NAC represents. And so as the public health emergency is unwinding, a lot of these relief measures are being unwound as well. So the public health emergency expired on May 11th, earlier this year. Before that, actually, the Medicaid continuous coverage requirement was decoupled from the PHE, and that actually expired on March 31st, which triggered eligibility redeterminations and renewals for the first time. And these renewals are taking place over a 12 to 14 month period, which will end May 31st of 2024. With the expiration of the PHE telehealth coverage, the mandated telehealth reimbursement for Medicare and Medicaid expired, but these have been addressed through legislation, at least through the end of 2024. So I'm not going to talk too much about that today because there's not an immediate policy solution there. It's actually taken care of for a little bit more time. And then finally, coverage for COVID-19 medical interventions, so vaccines, tests, and treatments. With the expiration of the PHE, the CARES Act coverage requirement expired, which triggered a transition to commercialization and cost sharing. And so I'll talk a little bit more about that as well. But first, talking about Medicaid renewals. So unwinding the Medicaid continuous coverage requirements. On March 31st, that expired, as I mentioned. On April 1st, the very next day, coverage terminations were allowed to resume for those enrollees who were determined to no longer be eligible. All states must initiate renewals for all of their enrollees by March 31st of 2024, which is that 12-month period to initiate renewals. And then all states must complete the renewal process for all enrollees by May 31st, 2024. And so that gives them 14 months from the expiration of this provision to complete all of their eligibility redeterminations. Meanwhile, the federal Medicaid matching rate, the FMAP, will phase down until December 31st. And again, this enhanced FMAP, even as it's phased down, is attached to some requirements, which are to conduct renewals in accordance with federal guidelines, as well as states must make a good faith effort to contact enrollees and ensure up-to-date information before they terminate coverage based on eligibility. So where are we now? The continuous coverage requirement and its expiration represents one of the most significant shifts in coverage that we've seen as a country since the passage of the Affordable Care Act. 93.9 million individuals were enrolled in Medicaid and CHIP in March 2023. And as of November 1st, which was last week, at least 10 million people have been disenrolled. And so early projections of losses in coverage were likely underestimates, we're learning. And we're also learning that 72% of all people disenrolled have had their coverage terminated for procedural reasons, which means they were not, the state Medicaid agency was not able to determine their eligibility because folks didn't respond to requests for information. They didn't fill out their forms. They weren't able to be contacted, and so they were taken off the rolls. Over 4 in 10 of these disenrollments represent children who were enrolled in Medicaid and CHIP, and so children are losing coverage at an alarming rate, and we're keeping a close eye on these numbers. The data on Medicaid renewals is coming from a few places, and so just for some context, community health centers serve about 15 million patients who are enrolled in Medicaid and CHIP. And this is in 2022, so that in the middle of the period of this continuous eligibility requirement, we're still tracking, we're still learning about how many of these patients are among those who've been disenrolled. Many state Medicaid agencies are reporting their data to CMS and nationally, and so there are some data reporting requirements attached to the enhanced FMAP and the phase down. So 45 states are reporting their monthly enrollment data and disenrollments. Additional data is collected by CMS on some quality benchmarks that I'll talk about more on the next slide, but 23 states are reporting those quality benchmarks to CMS. And then 41 states actually have online data dashboards that folks can go to look at unwinding data. And a few things to highlight from the data are the types of renewals. So ex parte renewals are automated renewals using existing data from other federal programs like SNAP or from the IRS. And those renewals are completed before requesting that enrollees have to complete paperwork. And so it basically means ex parte essentially means without paperwork in my mind. And so this is to essentially help to reduce administrative burden for the state, and it can help reduce some of these procedural terminations, which are essentially, as I mentioned, when there's no definitive determination of eligibility. So maybe because enrollees don't receive renewal notices or they face barriers to completing the redetermination process, Maybe they're not able to be contacted. Maybe they don't have stable housing and don't have a consistent address. And so there are some data on this slide essentially showing states that have over 50% of procedural terminations, which we see as sort of a red flag, and those are highlighted in orange. On the other hand, states that have high rates of ex parte renewals, which means that folks are being renewed without having to complete any paperwork. And we have some states that are doing pretty well in that area, as well as states who aren't doing well, and those are also flagged in orange. States are actually required to go through the ex parte process. And so if they are not using ex parte renewals, then that is also seen as a red flag. And so some of these ex parte renewals, while they are seen as sort of a positive to facilitate the renewal process, recently CMS, and this is actually on the right over here on this slide, so I'm going to go right to left. But recently CMS discovered that eligible individuals were being improperly disenrolled due to ex parte renewals conducted at the household level rather than at the individual level. But essentially what you need to know is that ex parte renewals need to be processed at the individual level, and they, even though it's automated and that's seen as a good thing, lots of people in households, if one person wasn't eligible, the entire household would be disenrolled, which is obviously unacceptable because lots of people who are eligible for Medicaid are being disenrolled. And so CMS sent letters to Medicaid directors reminding them of this and directing them to pause their procedural terminations until this issue could be resolved, reinstate coverage for all individuals who were improperly disenrolled, and then fix their ex parte systems and processes and implement a mitigation strategy. Another recent issue that CMS has addressed through a letter to Medicaid directors is on these performance indicators that CMS is tracking to ensure timeliness and compliance. And so there are a few categories of data that are being collected. One is on call center operations. The metrics are average wait time and average call abandonment rate. And these call centers are important because as enrollees are trying to complete the redetermination process and provide the information that's needed, lots of folks have questions and need to get their questions answered. And so these call centers are really important to facilitate that process and to help enrollees understand what they need to do and the steps they need to take to ensure that there's no lapse in their coverage. And then of course, CMS is collecting renewals data. So percent of beneficiaries terminated specifically for procedural reasons, because again, this is a performance indicator. And then finally, application processing time. So the percent of application determinations that are processed in more than 45 days. And so those letters are linked in these slides. You can also track the data that CMS has by state to see how your state is doing in these areas. So with all of that said, I know that's sort of a whirlwind, but NAC is hosting a webinar series on both open enrollment and Medicaid renewal. So if you're interested in learning more about this topic, some of my colleagues who are working much more closely on this issue will dive deep. We also have some remarks from CMS leaders. We also have the Kaiser Family Foundation, who is providing a lot of the data that was on the slides that I just showed you. They are both going to be presenting at those webinars. And so the link to register is also in these slides, which I can share. And then we have a Medicaid renewal webpage on our website, which is linked in these slides. We have things like Medicaid revenue loss estimator, where health centers can actually enter in the number of patients who at their health center who've been disenrolled, and then our calculator helps them figure out an expected impact to their revenue based on their patient payer mix changing. And then understanding presumptive eligibility, breakdown of Medicaid renewal data metrics, and then an issue tracker. So these are all resources that are available to the public on our website. They are tailored for health centers, but other primary care practices could use these calculators as well. Keeping in mind that your Medicaid reimbursement rate might be different. And so, those projected losses might be slightly off. And then finally, the NAC blog is regularly updating the field on the status of Medicaid renewals, especially how health centers are actively working to keep patients connected to coverage through communications campaigns, through eligibility and assistance workers, and through outreach. And then going back to this COVID-19 intervention coverage, and I'll try to cover this quickly, but as I mentioned, expiration of patient access protections to COVID-19 vaccines, treatments, and tests is resulting in cost sharing for a lot of insured folks. And then for our uninsured and underinsured patients are going to be facing some cost barriers to accessing these. And so this table, again, I'll share these slides so we don't have to go over it, but this table summarizes coverage based on insurance status for each of these COVID-19 medical interventions. And then I'm going to talk specifically about access to vaccines for uninsured and underinsured patients and how they can access vaccines at no cost through the CDC Bridge Access Program, which offers free vaccines to uninsured and underinsured adults, and is doing this through local healthcare providers, including state and local health departments, federally qualified health centers, and pharmacies. And so, there are some hiccups with this. Essentially, health centers have to get vaccines through their state and local health department. They have to enroll in the program. And we've been hearing that there are some challenges and that distribution of vaccines from the CDC Bridge Access Program has not yet reached patients at health centers and isn't quite meeting demand. But we're not sure the degree to which this problem is occurring across the country. So we actually have a survey in the field right now to understand health center access to vaccines through the CDC Bridge program. We see that most of our health centers who have responded so far have received 100 doses or less of the vaccine. And the reasons why vary. Some health centers haven't requested them because demand for vaccines at their health center is really low right now. Others have been told by their state health departments that there's an insufficient supply of vaccines through the CDC program. Others have had issues with enrollment or data sharing between the health center and their state health department. And so there are a variety of issues occurring. And so NAC is trying to quantify those issues through this survey so that we can continue to advocate. We regularly meet with the CDC, with HHS and the White House to make sure that uninsured and underinsured patients can access these vaccines at health centers who don't turn patients away, but are going to take losses if the health centers have to purchase commercially available vaccines and then provide them at no cost to their uninsured patients. We want to make sure that health centers have access to vaccines through the CDC Bridge program so they don't have financial losses. So that was a whirlwind, but I'll pause for questions, and my contact information is right here. If you want to, contact me after this meeting, I'm always happy to talk with you offline. Thanks.
Gracie, thank you. I know that was a whirlwind of information and very helpful information. So thank you for sharing. And you're welcome to drop the website and your contact information in the chat, just in lieu of time, but we will get the information out to all attendees as well. So Rochelle, I'm going to, in lieu of time, I'm going to go ahead and close out. If there are any final comments, we'll certainly welcome those from anyone, any community partners. But we want to thank all of our presenters for the informative and engaging presentations. We've had some great conversation, great exchanges, information shared. Thank you to our sign language interpreters. We've kept you quite busy. Spanish language interpreters, as well as our Zoom guru. Whitney, thank you for your resources and sharing your resources with us. And particularly to all of our community partners and participants, thank you, a huge thank you for joining today. And we greatly value your input, your time, and the work you're doing, the great work you're doing in our target and priority populations across the country. Thank you so much for what you're doing. And so we want to get your feedback. You see the evaluation survey on the screen. We'll also drop it in the chat. Well, we want to get your feedback on today's event. Well, this is a biannual event, as we mentioned at the beginning, and so we'll do this again later, probably in May or June. Again, based on your topics and your feedbacks, we want to hear what you have to say to help us make things better for you as we move forward over this year and hopefully beyond this year as well. So please, we encourage your feedback. And as we end, I also want to encourage you, each of you, as we talk about these 3 areas of focus today, but acknowledge and remain vigilant of awareness of AI in preparing your culturally tailored health messaging. Remember there is such a thing, and how do we address that? Consider the barriers and opportunities and benefits of using technology in this space. And so we will continue to enhance our platform that we're using to make sure that it's benefiting you, our partners, and your populations. And then also be aware and up to date of the potential policy solutions that are going through related to the end of the pandemic. And we will continue to keep you updated through our communication, through our email blasts, and through our social media and our communication dissemination channels. We will keep you updated in those forms as well. So I know our time is short. I won't go on. I really, again, appreciate it. And thank you so much for attending, and be on the lookout for additional information. And thank you all, and have a great rest of the day.